Myself, Dr. Jaideep Dhamele, presenting my talk on hip spica and walking hip spica technique for fracture sharp femur in children. Ideal treatment of the fracture sharp femur in children is one that control the alignment, length, comfortable for the child, convenient for the family, and causes the least negative psychological impact as possible. The main aim of the fracture sharp femur management in children is we wanted to maintain the length to achieve the good stability and avoid or prevent the deformity. These are the acceptable angulation for different ages. Birth to 2 year, varus vulgus we can accept up to 30 degree, anterior posterior up to 30, shortening 15. 6 to 10 year, 10, 15, 15. You can remember the mnemonics, you decrease the 5, 5. 11 year to maturity, varus vulgus 5 degree, anterior posterior 10 degree and 10 of the shortening. Management of the fracture shaft femur at 6 months to 6 years. The AOS guideline, early spica casting or a traction with delayed spica casting, femur fracture with less than 2 centimeter. Indication, transverse fracture or spiral fracture. Spica cast application for fracture shaft femur. We go step by step for the technique. Step 1, pre-operative planning on the radiograph. Obtain adequate sedation, assess the fracture stability with the help of telescopic test, apply cast liner, position on the spica table, apply cast padding, apply and mold cast, trim and finish the cast and remove the patient from spica table. Checklist, we want spica table, synthetic cast roll, gypsona cast roll, plaster roll, padding, stockinette, water. Always do the telescopic test before giving the spica. If the overriding of the fragment on lateral X-ray was more than 25 mm, patient considered to be as a spica cast failure. Position on the spica table. Leg position is very important. 45 degree of the hip flexion, 30 degree of the hip abduction, 50 to 70 degree of the knee flexion depending upon the fracture. Upper third, middle third, lower third to avoid the uh, compartment syndrome. Always put the folded towel over the abdomen to avoid the pressure. Cast padding always start below the nipple line to above the middle malleolus on ipsilateral side. We prefer to include the foot to avoid the rotational. Apply an anterior valgus mold to involved thigh to recreate the anterior bow, address the tendency of the femoral shaft fracture to drip into the varus. Always reinforce the with slab spica at groin, at hip and at knee. Final position. Finally, you have to trim and finish the cast. Inspect the groin region for the rough edges. If there, you can trim with scissor and keep the abdominal window for comfort and breathing. So short video of the spica application. Here you can see 2-year female child came to emergency department with history of fall from the height, hemodynamically stable, deformity and shortening of the right thigh, no other injury. Requirement for the spica, we need wooden plank, stockinette, soft roll, narrow scale, plaster of Paris, water tub, sheet of cloth for counter traction. This is a very important position. You can see there. Position of the surgeon. Do the reduction under the C-arm. Apply the stockinette. Putting the sheet for counter traction. We need one of the assistant we can hold because during the manipulation of the fracture, reduction will be this. Apply the stockinette on the affected side and affected on normal side half. Confirm the reduction under the C-arm. Start the rolling of the soft roll from the abdomen, affected side till the ankle and foot. Check 3-point pressure. Put the extra padding over the pressure point, just like a groin and posterior of the knee. Because when we are manipulating, that will give rise to spica sore. Complete the application of the soft roll. Cut the gypsona. Keep the plastic bag within. That will save the plaster and water. Start application of the spica from abdomen. Complete 3 roll. Then start finishing at the groin gently. You can see the green towel my assistant is holding. Always roll your gypsona in figure of 8 fashion. Mold the cast to maintain the reduction. First complete the above knee, then complete the below knee. You need to mold the proper cuts. Reinforce the joint with the slab as mentioned previously. Again another roll figure of 8 fashion to reinforce your spica, otherwise the spica will be broken. Complete the plaster on opposite side with maintaining the human position. Protect the edges. Reinforcement at the joint level with additional POP or slab. Finally, we have to complete the foot part. Mold the edges properly. Complete foot portion. Fix the abduction bar to maintain the stability. Always check spica edges, adequate spacing, and finally you can complete your spica with the scotch cast. Pat the edges with micropore. Post-op spica care is very important. Proper positioning, avoid soiling, watch for the crack, use the dipore, report immediately if there is a pain or plaster tightness. Do not insert any object inside. Problem of itching and can be avoided. Post-op protocol, monitor for the reduction, spica for 6 to 8 weeks. These are the some cases. 3-year female child, left shaft fracture treated with close reduction and single hip spica. At 3 weeks, single leg spica child started turning supine to prone to. At 6 weeks, she started full weight bearing. You can see the X-ray, good consolidation. At 8 weeks, fracture is healed. His child is able to sit cross leg and standing on single leg stance. Another case, 6-year child treated 10 days in TT spleen outside. We did the close reduction and single leg spica. 3 weeks X-ray. It's a very good single leg spica videos available on postnaacademy.org. 6 weeks, good consolidation. 2 months, full range of movement. She is walking without the limb. Walking is Spica cast application. That's a very good study from JPO 2006. 45 kids, only one non-malunion. 62% kids walked. 5 casts broke at the hip. Another paper from JBGS 2021, prospective study of the 45 kid regular versus the walking spica. All are low energy trauma. No malunion in walking spica group. Regular spica cause considerably greater burden of the care. Ambulance transport required more in regular spica versus the walking spica. These are very good randomized control trial by JBGS 2012 do not find any significant difference in radiological and functional outcome between single leg versus a double leg. Single leg spica afford more comfort during the sitting and greater easy on leaving the family home. Fewer care gear needed to take time off the work. Complication acceptable radiological outcome appears similar in both the group. Spica care is very important. Place a small diaper over the groin inside the cast to prevent the cast swelling, and second, larger diaper over the outside the cast to hold the smaller diaper inside place. Post Spica application protocol. Following cast application, distal neurovascular strategy is assessed. Caretaker are trained in cast care, safe patient transport, feed the child in the car while going from the hospital. Follow radiography always take at day 10, 4 and 6 weeks of the cast application. Angulation less than 15 degree and shortening less than 2 centimeter can generally be acceptable in patient with mid-shaft fracture. Angulation more than 15 degree can be managed with the wedging of the spica cast in OPD basis. Single leg spica of the fracture shaft femur less than 5 years is provided reliable outcome with few complications. Advantage of single leg spica. Walking spica is ideal in stable low energy fracture in toddler. It is applied with the ipsilateral knee in 45-degree flexion with the hip in 45-degree flexion, 30-degree abduction, 15-degree external rotation. Hip should be extensively reinforced anteriorly to avoid the breakage. Additional advantage offered by the walking spica over the conventional spica are improve the function, care and reduce the chances of the spica syndrome. Disadvantage is the increased chances of loss of reduction compared to conventional spica. Take home message. The major determinant of treatment modality is the age of the child and type of the fracture shaft femur. Spica casting for management of the diaphyseal femur fracture continue to be mainstay in the modern orthopedic treatment for 6 months to 6 years. Angulation less than 15 and shortening less than 2 centimeters can easily be acceptable in mid-shaft fracture. Single leg spica resulted in fewer parent day off work, easier patient transport and increased ease of the sitting. Thank you.